The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon, everyone, and thank you so much for joining us over the lunch hour for our webinar today. That is to improve colorectal cancer screening rates and save lives. My name is Rebecca Valley. I'm a Facilitation and Improvement Specialist with the Oregon Healthcare Quality Corporation. And this webinar is part of an ongoing public health and primary care webinar series featuring public health experts who can offer valuable training and resources to primary care providers and ideas and examples of how the two can work together to improve population health. My role today will be predominantly to moderate and field questions because we have two very capable presenters. And before I jump into that, a quick heads up about some of the interactive pieces of our technology today. We do want to hear from you, and we welcome your questions at any time. If you take a look on the right-hand side of your screen, you'll see this little questions pane for Q&A. Please go ahead and type your questions away at any point throughout the presentation, and we will field them and send them to our presenters to respond to at the end of the presentation. We do have plenty of time set aside. Please note that the webinar recording with the link and the slides will be made available after the presentation and will be posted to our website. A few words about the Patient-Centered Primary Care Institute. So the Institute is a public-private partnership that was launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation. It is currently managed by QCorp. Together with the experts that we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to please visit our website at www.pcpci.org to access any resources, including our previous webinars. You can also sign up for our email list on the website, which is how we will announce additional web-based and in-person training opportunities and future Institute programs. As I mentioned, the Institute aims to help primary care practices achieve recognition as primary care homes throughout Oregon's Patient-Centered Primary Care Home program. The model is a set of standards organized under the 6 core attributes listed here. And you can visit the PCPCH program website at primarycarehome.org.gov to learn more. But without further ado, I would like to introduce you to our fantastic presenters today. We have on the line with us Patricia Schoonmaker, who's a health systems coordinator in the Health Promotion and Chronic Disease Prevention HIPCDIC section of the Public Health Division. She provides strategic direction for HIPCDIC health systems related efforts with a current emphasis on increasing colorectal cancer screening among Oregon adults. Patricia has expertise and experience planning and implementing data-driven chronic disease prevention programs, strategic planning and partnership and patient engagement strategies for chronic disease prevention, early detection, and self-management at the State Public Health Division and 2 Veterans Affairs Medical Centers. We also have with us Gloria Coronado, who's a PhD, an epidemiologist, and the Mitch Greenlick Endowed Senior Investigator in Health Disparities at Kaiser Permanente Center for Health Research. She's completed her training at Stanford University and the University of Washington. Dr. Coronado's research has focused on understanding and addressing disparities in the occurrence and burden of disease in underserved populations. with a special emphasis on the Latino population in the Pacific Northwest. She has developed several innovative and cost-effective interventions to improve rates of participation in cancer screening among Latinos. She co-directs the STOP CRC program, a program that uses health systems approaches to raise the rates of colorectal cancer screening in federally sponsored health centers in Washington, Oregon, and California. So with that, I would like to turn it over to the capable hands of our presenters. Thank you so much.
Oops. All right, and thank you, Rebecca. We are delighted to be a part of this series, public health series, so thank you for joining us to talk about colorectal cancer screening. Basically, Gloria and I will be going over some information about the context in Oregon, sharing some data, screening options, best practices, and some resources that we hope will be helpful to you. And let's see, mine is not advancing, Rebecca. Thank you. So this is all about prevention, and we are very excited that there is not only a national movement but Oregon movement about increasing colorectal cancer screening, the focus on prevention. Next slide. And it's important to know that increasing colorectal cancer screening in the last few years has become a huge national priority. Colorectal cancer continues to be the second leading cause of cancer deaths nationally and in Oregon, second to lung cancer. With the increased coverage and preventive services through the Affordable Care Act, individuals still continue to, individuals with insurance go unscreened. And our data show that there are health inequities that we're working really hard to change, differences in racial, ethnic, and geographic areas. And I just feel it's important to point out one key issue about colorectal cancer screening is, quote, the ick factor. Individuals don't come running to get this test, and so we have a lot of work to do to be sure that we make screening acceptable and accessible. And the key group that has created this movement is the National Colorectal Cancer Roundtable, and what you see is their phrase and their logo. 80% by 2018 is the national goal. Next slide.
Patricia, you should be able to advance the slides. You click on them and then with your mouse first, and then use your forwarder. There you go.
Okay. I moved the mouse because I thought it was distracting, so okay, I'm with it now. So in screening, there has been strong support for colorectal cancer screening in Oregon, and over the past 10 years there have been 3 bills that are listed here. The first in 2005 basically mandated colorectal cancer screening for Oregon issued insurance plans, and then following the Affordable Care Act, work was done to remove the out-of-pocket costs that were sometimes happening with, in particular, screening colonoscopies. So there were 2 series of legislation to make sure that a screening colonoscopy and a follow-up with or without removal of polyps has no cost sharing. So one question you might think about is how prepared are our clinic settings to be implementing this to make sure patients don't get any bills. So in public health, we always defer to the data. We start with the data, so I'm going to share a little bit about what the data tells us. And one phrase we like to use is, what gets measured gets changed. So in Oregon, we're very fortunate to have 2 sources of population health data, and one is the Behavioral Risk Factor Surveillance System, affectionately known as BRFIS, and that's where we get, for Oregon, we come up with, we get a number of what is the screening prevalence, what's the percentage of Oregon adults getting screened. It's a telephone survey. And what's great about it is it's not only done in Oregon, it's done in every state, so we can compare ourselves to other states. Another key data source is the Oregon State Cancer Registry. Cancer became a reportable condition in '96, and data are reported by healthcare providers at the local level, and it comes to the Oregon Health Authority. And this is our source of incidence, mortality, and stage of diagnosis data. So through our BRFIS data, we're able to track that screening has increased 50% since 1997. In '97, we were at 44%, and we are now at 66% when the most recent year data for 2014. Given that, with 66%, that basically means 2 out of 3 Oregonians are not getting screened as recommended. So that is something that we want to change. This shows the, for 2014, the BRFIS from the general Oregon population is the green, 66%. And the blue is Medicaid for the same year. The questions asked: have you ever had been screened? Have you had a blood test? How recently? Sigmoidoscopy, colonoscopy. It's the same questions. And you see a significant difference between Oregon's general population and Medicaid. So that's one reason that it's great that the CCOs, coordinated care organizations, have taken this on as an incentive metric. We also, in our screening data, we always want to be looking at disparities, and this is a little bit, the data are a little bit old because we have to combine multiple years of data to get numbers large enough, since Oregon is fairly low in comparison to other states with regard to our racial ethnic profile. But these numbers continue to be consistent even with the most recent Medicaid data. The lowest, what's important to note, we have a lot of work to do among certain populations, and specifically we see that the Hispanic Latino population is the lowest, and has been getting attention from groups like Providence and Gloria's CRC project and others. So now we look at data that we get from the Oregon State Cancer Registry, which gives us the new cases each year, deaths, and stage of diagnosis. And you can see that over 1,600 individuals in 2013 heard the words, "You have colorectal cancer." You can also see from these numbers that it's pretty much an equal opportunity diagnosis. There really are not significant differences between men and women. And one thing that we always want to consider and keep in mind is that any diagnosis is a failure of prevention or finding those early stages where things are more treatable. A key thing from our registry data, what we look at is the stage of diagnosis, and very, very important for colorectal cancer is the difference between early stage and late stage. As you see, late stage is the green bar, 52%, which basically means 1 in 2 are diagnosed at late stage, and that compares to breast cancer where 1 in 4 are diagnosed at late stage. So these are really important issues, and again, we can do better and keep that screening goal in mind of 80% by 2018. Again, just like with screening, we look at late stage diagnosis, and here we see some real disparities, inequities, with the highest being 57% among the African American population. And here's where we see what we consider to be the impact of lower screening rates, the 53% among the Hispanic Latino. And here's the number that shows the total deaths among men and women, 669 deaths in 2013, and again, this is restating second leading cause of death and inequities. an additional piece here at the bottom. If we reach 80% screening, nearly 3,000 Oregon lives would be saved between the 18 years of 2013 to 2030. So we have our task set before us. And I want to close with this last data slide showing that we look at differences and trends over time. Through these maps, we're able to see where death rates are higher. And in this slide, the darker blue counties have the highest death rates. And so this is the final closing and saying, let's work together to change these numbers. And I think we are now passing this on to you, Gloria.
Wonderful. Thank you, Patricia. Just to add to some of the background information on colorectal cancer screening, as Patricia noted, there's about a third of age-eligible adults that are not up to date, and many of those adults receive care at community clinics or safety net clinics. And what you see in the figure on the right of the slide is the national BRFIS data from 2012. And the comparison that we make here is to national data from federally qualified health centers in 2014, which was about 34.5%, and that's very similar to what we see in both Washington and Oregon. And so we know that within the community health center or safety net setting that the screening rates are substantially lower than they are for the general population. And this is important because, as Patricia mentioned, there's a really there's a lot of cancers that are being detected at advanced stage, and what we know is that if somebody's found to have stage 1 disease, their chances of surviving 5 years is 93%, but if they're detected with stage 4 disease, their chances of surviving 5 years is only 8%. And so this is why it's so important to focus on increasing screening rates. We know that with healthcare reform, there were a lot of new enrollees into the Medicaid health plan. And what this data show here is that the highest proportionate increase in Medicaid enrollees occurred among patients who are ages 51 to 64. And what we know is that those patients are the very ones that are eligible for colorectal cancer screening. And so there's a unique opportunity, I think, with Medicaid expansion to enroll and bring in patients who would benefit from screening. This slide talks about the fact that cancers that are found at later stages are associated with greater cost, and so we're losing healthcare dollars, we're losing lives to a disease that's preventable. Now that we've talked about, the background information on colorectal cancer and the need for screening, I want to shift to talk about the screening recommendations. We know based on simulation modeling that there's a similar mortality reduction for patients who receive colonoscopy every 10 years and patients who receive FIT testing every year. And so both of those options are considered to be equally effective in reducing mortality from colorectal cancer. And as a result, many who do work in colorectal cancer screening state that the best test is really the one that patients will do because they're similarly effective. Recommendations by the U.S. Preventive Services Task Force call for high sensitivity fecal occult blood testing, which includes the new fecal immunochemical test each year, plus colonoscopy for abnormal test results, or colonoscopy every 10 years, or sigmoidoscopy every 5 years, plus interval FOBT or FIT. And by interval, we mean one at the middle of that 5-year period. We know that the Affordable Care Act, specifically the preventive health mandate, requires that screening tests recommended by the U.S. Preventive Services Task Force with either a grade A or B recommendation are covered with no out-of-pocket cost. And I think Patricia did a great job of showing how our legislature has kind of closed the loopholes with that the Affordable Care Act legislation to make sure that patients aren't falling through the cracks and experiencing out-of-pocket costs for any follow-ups. The U.S. Preventive Services Task Force's recommendations were updated in 2015, and they're currently in draft form. And the draft recommendations have made no changes to colonoscopy or fecal testing recommendations. There was a change that's made to sigmoidoscopy recommendations. So the old recommendation was for a sigmoidoscopy every 5 years plus interval FOBT or FIT. And the new recommendation calls for sigmoidoscopy every 10 years plus annual FOBT or FIT. There's no recommendation for CT colonography or the multi-targeted stool DNA test. And I think I turn this over to Patricia.
This is just one slide to show through our BRFIS where we ask what test have you had and when was it. It shows the predominance, overarching, overwhelming predominance of use of colonoscopy, and we're showing this to show the low use of the blood stool test, and that this is potentially for clinic systems a missed opportunity to offer a test that may be more acceptable and accessible to your patient population. That's it.
Great. So why is it important to include FIT as a component of a colorectal cancer screening program? So one reason is that patients are more likely to get tested using FIT, and there are many patients who will say, I will not get a colonoscopy unless I believe there's something wrong. And FIT testing can be really that evidence that there could be something wrong, and it can help motivate patients to get a colonoscopy. We know that in a variety of studies that patients are more likely to get screened if they're offered either fecal testing or the choice between fecal testing and colonoscopy. We also hear that there are some geographic regions in Oregon as well as around the country that have limited colonoscopy capacity, and so fecal testing allows us to identify those patients who in fact have the highest risk of having cancer, because 1 in 20 of the patients who have an abnormal fecal test result will be found to have cancer. And as I mentioned previously, fecal testing can motivate patients to get screened using colonoscopy, and we certainly see evidence of that in the data. This is data from a study that was done by Gupta and published back in 2013, where he enrolled about 6,000 patients from a safety net health system into a study that randomized them to either receive a free fecal test, free colonoscopy, or usual care. And what he found is that across all racial and ethnic groups, that the highest proportion screened occurred in the group that was offered free FIT. And what this suggests is that even when you remove the financial barriers to screening, free FIT was the screening test that most patients were likely to do. These are data from microstimulation modeling that was published in 2009, showing that in the scenario of 50% adherence, and you compare the offering of colonoscopy every 10 years to the offering of FIT every year, that at the end of the day, you're going to be doing a lot fewer colonoscopies. And so if you start with a population of about 4,500 patients, the number of colonoscopies you do offering it every 10 years in the 50% adherence category is 2,250. On the other hand, if you began by offering patients FIT testing, the number of follow-up colonoscopies that you would do would be 1,670 over that 10-year period. And so at the end of the day, you're doing 580 fewer colonoscopies in that scenario. And why is that important? Well, it's important because colonoscopy is not without risk. And in fact, the risk of serious complication has been estimated by T.R. Levin at Kaiser in Oakland as 5 per 1,000 patients. This next slide presents a really interesting study that took the scenario of having $2 million over the course of 2 years. So this is an actual situation in South Carolina where the legislators said, we have a problem with colorectal cancer screening. We want to dedicate $1 million in each of 2 years to try to address it. And so this group out of the Netherlands did some microstimulation modeling to determine, okay, let's say we spent all that money on colonoscopy. So that in this table is a column that says colonoscopy program. And then let's compare that to instead spending all of our money to promote FIT testing. And let's assume that all that the number of patients screened was going to just be equal to the amount of money that we had. And so in the colonoscopy program, almost 3,000 patients were able to get screened, but you compare that to the annual FIT program, and about over 21,000 patients were able to get screened. So that's nearly 8 times as many. What we see is that in the annual FIT program, at the end of the day, you did about half as many colonoscopies. You prevented 2.5 times more colorectal cancer cases, and you prevented over 4 times as many deaths. And the number of life years gained was about 4-fold in the FIT program scenario. And so what this suggests is that by offering FIT, at the end of the day, you're going to get more patients screened and save more lives from colorectal cancer. So I'm a big proponent of FIT testing, but at the same time, I want to say that what we need are high-quality FIT programs. And there are a variety of FIT tests that are available on the market, but they vary with regard to the performance, the cost, the number of samples that are needed for the test, and how and where it's processed. And some of the FIT tests that are on the market, in fact, have very little evidence to support their use. And I want to review that with you in the next couple of slides. So these are data from the published literature on a variety of FIT tests that are specifically known to be used in the state of Oregon. So we know this from our work with STOP-CRC as well as other collaborations we have going on in the state. And the second column shows a percentage positive based on the published literature. And what you see for the first 4 tests, there is some data from the published literature, but for the 4 on the bottom of the list, there's really nothing available in the published literature that speaks about their percentage positive. And then sensitivity is another measure of the accuracy of a test, and it's the proportion of actual positives that are correctly identified as having cancer. And so the column on the right shows those specific tests that have been evaluated in large numbers. But what we see from STOP-CRC, and so STOP-CRC is a study that involves 26 federally qualified health centers in Oregon and California, and overall we've identified 50,000 patients that are due for colorectal cancer screening, so our numbers are really high. And what we see are positivity rates that you don't see in the published literature, and in fact they're much higher than what you see in the published literature. I think the exception is FIT test D, which is OC Micro. This is a FIT test that's used at Kaiser Permanente. Nationally, it's used by Group Health, and it's used by about 3 of our federally qualified health centers in STOP-CRC, and consistently it gets about an 8% positivity rate. The FIT test C is Ensure, which is a product that is owned by Quest and processed by Quest. It's a 2-sample FIT test product, and the published literature shows that the positivity rate for that product, I'm just going to go back one, is about 4.6 to 5.6%. What we see in STOP-CRC is a positivity rate that's much higher. Each one of these bars represents a different health center. So across the different health centers, we're seeing a high positivity rate for that product. FIT test B is HemoSure. That's being used by one of the health centers in STOP-CRC. And again, it has a very high positivity rate. FIT test A is Consult Diagnostic. Both of these have not been evaluated in large numbers. We can't find a single scientific publication that talks about their performance characteristics. So in addition to assessing the positivity rate over time, which is something that we care about from a clinic perspective in terms of how many patients are needing to be referred for colonoscopy, the other aspect of monitoring your program is really thinking about how well patients are able to appropriately do the test, perform the test. And so these are data from a Plan, Do, Study, Act cycle at Multnomah County Health Department. And they chose to focus their PDSA on this topic because what they realized is that they were getting a lot of FIT tests, and they were using the Ensure product. They were getting a lot of FIT tests that were coming back without a collection date. And they knew that Quest would not process those tests without a collection date, and so they needed to be discarded. And so they started capturing the number of tests that were lacking a collection date, which is indicated in the dark part of the bars, and then the total number that were being thrown out because there was other issues around the collection. And so they did an intervention. They changed some of their processes, and they were able to reduce the number of samples that were needing to be thrown out because they were lacking a collection date or had some other issue with their collection. So what is it that they did? Well, they highlighted a portion of the introductory letter as part of their mail-out program to focus patients' attention on the section that indicated that they needed to add the collection date to their samples. They also developed a new insert that they put in with the fit kit that graphically showed the labels that patients needed to complete and where to put them on the fit test. So through that PDSA, they were able to reduce the number of samples that were needing to be thrown out. But my point is that it's really important to think about these aspects of the fit test that you're using, make sure you choose well, and that you monitor your program over time. So now I want to talk a little bit about colonoscopy. So we know that there are several advantages of colonoscopy. It can remove polyps. The screening itself can prevent colorectal cancer because about 6% of the polyps will be found to be precancerous. And it's an infrequent exam if the results are negative. So if a patient has no polyps, you only need to get a colonoscopy every 10 years. But the disadvantages are that it requires bowel prep, there's sedation involved, because of sedation, patients need to have somebody drive them home from their colonoscopy appointment, the costs are pretty high, and it can be logistically difficult because patients need to take time off work, they need to find somebody to drive them to the clinic, and there are risks associated with colonoscopy, and in fact that risk of serious complication is about 5 per 1,000. But one of the things we're interested in is how many patients who have a positive FIT test result will go on to get a colonoscopy, because we think of screening as a two-step screening process that starts with fecal testing, but the benefit of fecal testing is nullified if patients don't get a follow-up colonoscopy. And so this is a review of the literature, and I can tell you the literature is pretty sparse across different settings that have looked at adherence with follow-up colonoscopy. So the Veterans Administration, for example, have done 4 different studies that range in size, and they've reported a colonoscopy follow-up adherence of 42 to 59%, so a lot lower than you'd expect. The integrated care settings are typically group health in Seattle. Again, a couple of studies that vary widely in size, and they report an 81 and 82% adherence. In the safety net settings, there's been very little published literature and very small numbers, and the report is about 60 to 61%. And then there's been some national programs. In fact, the CDC program had an adherence rate of 97%. So we see quite a range, but we also see that there's kind of a lack of good literature on this topic. When we looked at this question within Virginia Garcia's data based on a pilot we did for Stop CRC, we found that overall 50% of patients who had a positive fecal test result received a colonoscopy within 18 months. But there were some interesting and notable differences with regard to race and ethnicity, with Hispanics being less likely to complete that colonoscopy. And this is in sharp contrast to some other data that we saw showing that Spanish speakers had a higher return rate of fecal testing on the direct mail program. And so we were really excited that the direct mail program seemed to enroll and engage a lot of the Spanish-speaking patients, but the real issue is that even when they had a positive test result, they weren't getting the follow-up colonoscopy. When we looked at the data about receipt of colonoscopy within 60 days, which is a standard that's set by the Veterans Administration, we found that the racial and ethnic disparity was even more stark. So what are some best practices with regard to improving rates of colorectal cancer screening? Well, we know that the Community Guide for Preventive Health Services recommends client reminders, small media, one-on-one education, and reducing structural barriers. There's insufficient evidence to recommend client incentives, mass media, group education, or reducing client out-of-pocket costs. And when we review the literature, we see a variety of strategies that have been attempted, some of which combined multiple recommendations by the Community Guide. So for example, the direct mail program has some strong evidence to support it, particularly for underserved and rural populations, and it combines kind of a small media approach as well as client reminders and reducing structural barriers, particularly if the fit kit is offered for free. So we see that there's a very strong evidence for direct mailing of fecal tests to patients' homes, and I think that evidence is across multiple settings, including integrated care settings as well as community health centers. There is strong evidence for flu-fit programs, although there's quite a smaller number of studies that have evaluated it. And then the other types of interventions that have been tried include improving the clinical processes, patient navigation, education at clinic visits or delivered by lay health advisors, or using media, or in combination with clinic and community settings. These are associated with either moderate, low, or insufficient evidence to support their use. So what we consider to be best practices are really investing in the readiness. And when we started Stop CRC, it was really important that clinicians be engaged in the work, that sites choose a high-quality fit test. When we started, almost all of the sites were using a 3-sample FOBT, and so many of the sites chose a fit test to work with. And then it was really important for some sites to update their health records with historical colonoscopy information. They could do this either by scrubbing the chart or by obtaining claims data from their Medicaid health plan. Promoting a 2-step screening process, which includes a high-quality fecal test plus colonoscopy follow-up, is important. Planning for multiple strategies. So often one single strategy is not going to be enough. Oftentimes, even with a direct mail program, it's important to make sure that fit kits are being distributed in clinic, make sure the MAs are well trained to discuss fecal testing with patients, et cetera, et cetera. Having a process in place for updating your colorectal cancer screening information in the health record is important. Tracking and monitoring the success of your program, and specifically tracking the quality of your fecal testing program by looking at positivity rates as well as any fit kits that are being thrown out because they're not completed properly. And then we encourage sites to make improvements using the Plan, Do, Study, Act approach. So now that I've covered those topics, I want to turn it over to Patricia to talk about some of the resources and tools that can help your efforts.
All right. Thank you, Gloria. I'm pleased to share a campaign that the Oregon Health Authority created because about 5 years ago we were questioning what can we do to help reach those individuals who are not getting screened, and we worked with our health media contractor and developed a small media effort that can be used to support patient reminders. And inherent in this, and not surprisingly, we conducted focus groups, and we're hearing that some of the national campaigns just were not going to fly in Oregon. We heard real clearly we want to hear from trusted individuals and local folks to really make a tailored campaign. So the result was that we developed this campaign that uses local spokespersons. It can be used with payers, providers, or community members, and it's all about sharing personal stories and encouraging others to be screened. Those are individuals who have been screened are the key actors in this campaign. In the focus groups, what Oregonians told us, and this was in urban and rural areas as well as among the African American and American Indian, Alaskan Native population. My doctor didn't tell me to get screened, it costs too much, there's no cancer in my family, or I don't have symptoms were some of the main themes. And this campaign, with using these materials, can support you being able to open up a dialogue and talk with your patients and clients to have a conversation to let them know the importance of screening. And there are a variety of tests, and as Gloria has said, that the best test is the one that gets done. And as you see, these are all individuals who have been screened in these images. and have agreed to share their story. And that is really the strength of Oregon's campaign, using the faces and voices. And this campaign, I'm delighted to say, has been featured in national webinars and at conferences. When we piloted this, it was in 2011. Clatsop County was selected for the pilot because they had the third highest death rate in Oregon from colorectal cancer screening. And during that time, during their pilot, they demonstrated a 31% increase in screening through the collaboration between individuals at their Columbia Memorial Hospital Medical Center and their local spokespersons. It was real clear that we wanted and needed to have a focus on the disparity between the Hispanic Latino population. So there were focus groups conducted, and the goal was to not just translate the existing materials, but to develop some key messaging and some pictures. So not surprisingly, the focus was on the family, females as decision makers, concern about cost and embarrassment, and the importance of trusted individuals. And as you can see, the key difference is this includes two individuals who are having a conversation, and it's not the one person just saying, I got screened. One of our materials that we have flyers and posters, and these can all be used, available to your organization if you wanted to use the template and tailor this with some of your own slides, your own photographs. But this is a unique example that I'm excited to share because this was a collaboration where the county health departments in Lynn, Benton, and Lincoln had already been working together, and the inter-community health network coordinated care organization stepped up and said, we'd like to work with you. And they provided some funding support and actually a process to create these this collaborative brochure that they are now using in their clinics. So the last slide was the front and back cover, and this is the inside. You can see how it's set up with their local spokespersons in each of the 3 counties, and then their own message. This is telling their story with the focus. On the left-hand side, you see the words, people are much more likely to get screened if they're encouraged by someone they know and trust, a spouse, partner, friend, coworker, their employer, or doctor. So again, as I said, you can consider using these materials as is, the posters or brochures, or create your own, and we could set you up, connect you with our health communication contractor. And we really encourage looking at how you might have existing education activities or screening activities within your clinics where this can be a part of your patient reminder systems. Another resource that's important to share is the group that does the 80% by 2018. They have key leadership from the American Cancer Society, Centers for Disease Control, and also many other professional associations, and they have come up with a lot of materials. You see a sampling here, and some of these are just 4 pages. Insurers working together to save lives, primary care physicians. They have a wealth of resources that are for providers, the general public, and other resources talking about quality screenings, such as some of the information that Gloria has just presented. So I feel that this is a key group to know about. And one of the resources that the American Cancer Society and the Roundtable created was, gosh, it's a document over 100 pages long. This is a synopsis. It's a short 8-page document that talks about the 4 essentials or action steps, basically the importance of establishing a standardized clinic system to increase screening. And as you can see, it has the steps of making a recommendation, emphasizing screening, and the more people who talk about it, the better. Develop a screening policy involving your staff, engaging your team, be persistent with reminders, and that all-important measuring and tracking progress to know what's happening and what is not. Again, the what gets measured gets changed. So I just want to highlight this, and we've got the reference to it at the end, but this is a key document that I think is the most simple step-by-step guide as a really quick reference.
Yeah.
So go ahead.
Oh, yeah.
Go ahead, Gloria.
Okay, so just to conclude, there are some national and state data that show that colorectal cancer screening rates are low, and they're marked by health disparities, particularly among African American and Latino populations. FIT testing and colonoscopy are similarly effective at reducing colorectal cancer mortality. FIT testing is an important component of a colorectal cancer screening program, particularly because patients prefer it. It can motivate patients to get a colonoscopy, and it can help identify patients who are at highest risk of colorectal cancer and make sure that they get into colonoscopy, especially in regions that have limited capacity. But there are some important ways to monitor your FIT testing program and make sure it's a high-quality program. The first is choose a high-quality test, and the second is to monitor both the positivity rates as well as any issues around patient completion. The direct mail programs have the strongest evidence to support their use. FluFit is also supported by the research, but there's been fewer studies to support that program. And there's a variety of resources that are available both locally and nationally that can help support your efforts. So with that, I'll turn it back to Rebecca.
Okay, thank you so much, Patricia and Gloria, for sharing all of that data. And this is a really important topic and clearly very interesting to our audience, as we got so many questions during registration. I know several of you submitted questions when you registered, but please do feel free to continue sending us your questions via the questions pane. It's on the right-hand side of your screen, and you can just chat in, and we'll sort them and present them to our presenters. But while people are continuing to do that, Gloria and Patricia, I know many people asked during registration and have submitted this morning or this afternoon, basically asking what are the best practices for improving the screening rates. I know you have already touched on this a bit, but I think it's come up again and again. And I'm wondering if maybe we could go back to the slide on the community guide recommendations and just expand a bit on some of the intervention examples that you're familiar with, especially some successful ones, or maybe ones that weren't so successful, and why.
Yeah, really good question, and I can start. So client reminders are a successful strategy for a variety of cancer screening tests. So if you look at the community guide, it recommends client reminders for breast cancer screening, for cervical cancer screening, and colorectal. And so routinely, I think what we realize in the literature is that patients need to get reminded to get their screening tests on time. Client incentives is an interesting one because it's noted that there's insufficient evidence to support its use. And I have only seen one study that's looked at incentives, cash incentives to a direct mail program. And what this author did was randomize patients to receive either no incentive, $5, $10, $15, or $20 for completing a FIT test. And there was no difference in the groups based on the incentive that they received. This author went on to do a different study where they randomized patients to receive no incentive, $5 incentive, a 1 in 10 chance of winning $50 or a $500 raffle. And so of those, and I think it's a one chance in winning the $500, right? And so of those categories, the 1 in 10 chance of winning $50 actually had a significantly higher return rate than the other groups. And so I think that it's worth kind of thinking about how you deliver incentives if you decide to deliver incentives with your program, but there really isn't much literature out there to support its use, and certainly, programs don't want to offer incentives if those aren't resulting in higher return rates. Small media is really sending information to a targeted group, and so it's contrast with mass media, which is typically radio or television. And so small media is, mailing out a flyer or a letter that says you're due for your colorectal cancer screening, or, mailing a fit kit is an example of a small media approach. Group education is interesting because in the community guide there's insufficient evidence. We had some experience with Virginia Garcia that decided to call in all their patients that didn't respond to the direct mail program and have them do a group medical visit. And what they reported is that every patient that showed up for the group medical visit actually got screened. And so it was very effective at getting people screened, but I think the issue is making sure that patients attend that group medical visit. One-on-one education is one of those strategies that I think consistently across all the cancer screenings is thought to be effective. And reducing the structural barriers, what's meant here are, making the test free, making sure that patients have insurance, making sure that they have transportation if they need it, et cetera, that those factors can really help. And then the out-of-pocket costs, there's insufficient evidence to support that, although we certainly know that with the U.S. Preventive Services Task Force recommendations of A and B and the Affordable Care Act that screening should be associated with no out-of-pocket costs, especially with the legislation that's been passed in Oregon.
And I will just add one piece to that is I remember hearing at the Quality Health Outcomes Committee, which is the medical directors and quality improvement folks at for the Medicaid program, at their meetings where they have talked about the colorectal cancer screening and centric. For 2 years they have said, wow, we thought this was going to be easy and a done deal, and then they said it's not. And I just want to give a plug to the importance of being able to identify the population who is to be screened, is of that age, and then the importance of having a system and a process to refer and remind the individuals, and then also track who got screened, who didn't, and then who needs follow-up, and having that that closed loop process, which is supported by data as well as your clinical practices. I think we can't say enough about that, and also considering how to fit this into your regular practice and not asking someone to come in just for this issue, how to incorporate it, integrate it into your clinic processes.
Thank you, that's great. As a follow-up to that, do you have any ideas or have you heard of any great ways that practices are getting employees excited about asking patients and talking with them and trying to work that into the workflow about making sure that they're getting their patients screened?
Yeah, I think in SOP-CRC we certainly know that most of the sites include colorectal cancer screening as part of their regular scrubbing process, and they will incorporate that in their huddle, and some of them place standing orders for colorectal cancer screening. And then some of the clinics have done a variety of really innovative things, either wearing blue t-shirts during March, which is Colorectal Cancer Awareness Month, or wearing buttons that say that might just have a colon and a check mark, which got your colon, which stands for getting your colon checked, and it might prompt patients to ask a question about what that pin says. And there's been another program in Washington State that decided to combine fecal testing with their mobile mammography van. And so they created a poster that had this, that showed a woman, the backside of a woman wearing a bikini, and it says, ladies, like, protect all of your assets, to encourage them to get a fecal test as well as a breast cancer screening. So there's been a variety of clever strategies. Some clinics have also offered prizes to the medical team that has the highest screening rate, and so one of our clinics had the crappiest team award, and they created this little statue that they handed off to the team that got the highest score.
That's very funny. I think those are some great examples. I wanted to bring up an example that we had talked about before with the combining this with the flu clinic, and I know when we talked about this, you had said that there's maybe some mixed reviews out for combining colorectal cancer screening with a flu clinic or the reminders.
Yeah, it's a really good question. You know, one of the things that Kaiser does, for example, is that they promote colorectal cancer screening at almost every touch point. So if a patient shows up at pharmacy and needs to get their prescription refilled, the pharmacist can notice that they're due for colorectal cancer screening and remind them or give them a FIT test. Similarly, they've recently linked their dental records to their medical records so that even in the dental clinic you can get reminded about your need for preventive care services. And so I think Kaiser certainly maximizes those touch points. So one of the programs is FluFit program, which I think has been done at Kaiser in Northern California area, but hasn't been done consistently here in the Northwest. And I think that my impression, having worked with some of the community clinics to do FluFit, is that if a clinic has an existing flu clinic, that adding colorectal cancer screening can be very logical. And it may not be that much additional work because patients are already coming in to get their flu shot. You can offer them fecal testing, send them home with a FIT test, and you've killed two birds with one stone. If a clinic doesn't have an existing flu clinic, what I've heard is that it can be very challenging to kind of organize both at the same time. And so this one particular clinic decided to, you know, have 6 different flu fit clinics, and they started calling patients to invite them, and some of the patients said, well, I don't want my flu shot. And so the clinic said, okay, well, we'll mail you the FIT test then, so at least you can get screened using FIT. And then at the end of the day, after these 6 flu clinics, they handed out, I think, a total of 11 FIT kits and got 6 returned to them. And so it was a lot of effort for not much return. And that's why I think that it's important that it be an add-on to an existing well-attended flu clinic in order to make sure that the benefit of it will be worth the effort.
That's great. Thank you, Gloria. I think that's a fantastic example and good to keep in mind. I do want to be mindful of everyone's time. I know this is the lunch hour for many of us, or for many of you, and I want to thank everyone so much for being on the call today. And I want to thank Patricia and Gloria for talking with us. I think this has been a fantastic opportunity, and I just want to leave us sort of with this next step slide. I think, Patricia, this is your slide, and I think this is a really great slide. If either of you would like to leave us with a few closing remarks on sort of the next steps that attendees can make leaving this webinar.
Yeah, I'll start and then I'll hand it over to you, Patricia. I think that taking like a PDSA approach to your screening program is going to be important because oftentimes people can go in with high expectations like, oh, this is going to be easy. If we just do this single program, it's going to work perfectly. And I think what we realize in the course of STOP CRC is that designing a really high quality program is an iterative process. And so when I look at this diagram on your screen, I think, okay, yeah, you might have to go around the circle 2 or 3 times because oftentimes you don't get it right the first time. And I think that there's a variety of aspects of designing your program well, which is making good choices, monitoring your choices in your program over time, and then adding to it as you can to optimize it and improve that return rate either by offering automated phone call reminders or text message reminders or email reminders to your patients to make sure that they return their FIT test.
And I would just add that, again, this increasing colorectal cancer screening is not always an easy sell, and we really want to engage as many of the clinic staff and community members as possible. My image and dream is that wouldn't it be amazing if that they're hearing things in the community, they're hearing from their friends, and really normalizing the importance of this cancer, that we can prevent the deaths, and that's why this national movement has grown, because the forces are all aligning with the Affordable Care Act, and we have to figure the ways to get over the hump, and many groups, as Gloria said, are using humor and other ways of trying to get rid of that ick factor. But I say get your team and take the pledge for 80 by 2018.
Excellent. Thank you so very much. And thank you again to everyone on the call. Just a quick heads up that our next public health primary care webinar will be July 20th, probably in the morning. And that one will be about chlamydia screening and treatment. And then we have several other resources and references for everyone. The slides will be available for download along with the link to a recording of this presentation on our website within about a day, and we'll send a follow-up email to everyone who joined us this afternoon. But other than that, thank you so much, and thank you again, Dr. Coronado and Patricia, for your expertise today. This has been fantastic.
Thank you.
Thank you.
Have a great rest of your afternoon, everyone.